All right, well, good evening, I guess good morning to some of you guys. I'm going to assume that you can hear me and see me. This is a webinar from MyoPain Seminars and Eureka Seminars. My name is Rob Stanborough. I've seen the list of some of you guys, so I know some of you. This will probably take about 45 minutes to an hour, and there's a couple of things that we need to cover before we start. Okay, here I am in St. Augustine, Florida. This is one of my clinics right here, and I am a clinician. I was trained in the Hogeschool in Amsterdam. I was trained in the Netherlands, came back to the United States, was working as a clinician in neuro rehab to begin with, and then I made my way back into the outpatient orthopedic arena. Worked at a couple of different practices, and then finally back in 2005, 2006, I started my own practice, First Coast Rehabilitation, which during all of this stuff that's going on, we're surviving so far. During that time, I was an assistant professor at the University of St. Augustine, taught a number of classes there, and then made my way to dry needling. I was exposed to dry needling early on in my entry-level education, but when I came back to the United States, nobody was doing it. So I just kind of put it off to the wayside for about another 10 years. And that's when I hooked up with Jan Dammerholt and Bob Gerwin with MyoPain Seminars. But I'm a clinician. So what I'm going to do for the next 45 minutes to an hour is I'm just going to let you into my mind a little bit. I'm going through some research that will be sent to you, a couple of different articles that I've given to Jan to send to you guys in an email. And but myofascial manipulation is my passion. And this was a book that I co-authored with Bob Cantu and Alan Groden. And anything that's soft tissue related, which also includes dry needling, is something that I'm interested in. A couple of things, these are being recorded, and you will be sent a link in a few days with this recording. So if you missed something and you want to hear it again, that's fine. A couple technical things. If you don't have any audio, best solution that has worked with these things so far is to check out or log out and then log back in and see if that works. That usually remedies most of the issues. If you can't see me, then it might have to do something with your bandwidth or your internet connection. And then lastly, as far as technical issues, if you have any questions, go ahead and type them in the question section of your GoToWebinar. We don't use the chat part. It's just too difficult to monitor. So, but if you write your questions, I'll try to address them as we're going. I've already had a couple people send questions about they can't hear. So again, just if you have any questions, go ahead and send those to me and I'll read them as we go. Okay, and so all you guys that are saying hello, hello back. If you hear any noise in the background, it just started with one of our Florida afternoon thunder showers. So hopefully that won't be too bad. A couple of other things. Some of these webinars are for free, some of them are not, and any proceeds are going to go toward Futures Without Violence. So if you want to make some kind of donation or going to one of the other seminars that costs, then feel free to make a donation, and that will go to that cause. Okay. There's only 2 more left, so I'm late to the game. There's been several webinars that have been done, several free webinars. My colleagues at MyoPain Seminars and other places have provided these webinars through MyoPain Seminars. I'm late, as I said, but there's 2 more. So if you want to watch the ones that have already been recorded, you can go to MyoPain Seminars webpage and they'll be on there. Or if you want to catch these last 2, you can do those. Okay, so it's every Tuesday, 5 o'clock. And that being said, let's get started. Okay, so I guess everybody can hear me now, or Jan's in the background, I guess, answering questions about the sound. So hopefully everybody can hear me. But like I said, what I want to do for the next little bit is just kind of take you through my mind as a clinician. And I have been trained by MyoPain Seminars with the dry needling. I have been using dry needling in my clinics since about 2017. It's been a little bit of a struggle here in Florida, but we finally got it passed, and it was signed into law a couple of weeks ago. But so what I want to do is take you through these things that I have listed for. Instead of writing objectives, I just thought I would put some of these things here because I'm not sure where all of you guys are. I know we have people from all over the world, several different countries, different time zones. Some of you may have taken, some of you may have taken courses through MyoPain seminars. Some of you may not have. So I'm going to kind of start with the trigger point and give some foundation to that, the pain science behind it. But then I quickly want to go into the connective tissue and why that's important to me. Because to date, I've not been able to find a whole lot that correlates what happens to the connective tissue after the trigger point is gone. And so do we still need to treat the connective tissue? In my mind, I think we do. And I'll talk about the concept of tensegrity and maybe give some further understanding as to why I think the way I do, and the effects of immobilization. What happens to connective tissue when we are immobilized? And when we have trigger points, we don't move through the full range of motion. We're not able to generate the full strength. And I think the key component is the neurophysiological aspect of it. What we're doing with our hands, what we're doing with needles is neurophysiological. Everything I read more and more is founded on this neurophysiological principle of using our hands or treating manually. And then finally, I want to take you to one of David Simon's article that I read years ago about the manual treatment of the trigger point. And hopefully you guys will have some questions. You'll see, and I'll just let you know up front in case I have some academics out there that are going to be critiquing my webinar. You'll see that a lot of the research that I have is older research, and I did that for a reason, because it's some of the groundbreaking stuff that came out years ago. And some of these authors have passed away, and some of these authors you don't hear much from anymore, but they have made some significant contributions to our body of knowledge. And so I want to take you through that and let you see some of the stuff that I've read over the years. Okay. So if we talk about, wrong way, sorry. If we talk about the trigger point, here is a picture that Janet Travell took of a trigger point. Here is the sarcomere contracture here in the middle. It's a contracture, it's not a contraction. It's not under volitional control. And then you have sarcomeres out here on the outside that are stretched. Here's your neuromuscular junction on top. So I want you to remember this picture. I've got an illustration that David Simon uses, but remember this picture that we have here a sarcomere contracture here in the middle, okay? Now, when we know that when muscles contract, the smaller motor units fire first and the larger motor units fire last. And the larger motor units will turn on and then shut off. So if I'm holding my head while I'm doing this webinar, it's mostly smaller motor units that are holding my head up. But if I start to turn, or the very muscles that are holding my head in place, if I start to lift my shoulder or do something that requires more strength, the larger motor units fire and then they shut off. So it's the smaller motor units that are constantly firing, and those are the ones that we get a lot of trigger points in, and that's called the Cinderella hypothesis, the slide that I just showed you earlier. Okay, so what happens with a trigger point is we have acetylcholine that is used for an action potential. If you have an action potential, you'll have acetylcholine that will come through this synapse. This neurosynaptic cleft will go and synapse with the muscle, and you'll get an action potential, which is under volitional control, and you'll generate power or strength through the muscle. But with the trigger point, there's not enough acetylcholine here to cause a contraction, because the small accumulation is not purposeful. It's not voluntary. And so the acetylcholine will pass through the synapse, and what will happen is you'll get some sarcomeres, as you see over here on the right, some sarcomeres will engage. The actin and the myosin will engage. And this is built on the expansion of Simon's integrated hypothesis of trigger point formation. This was, again, an older article written by Dr. Gerwin and Jan Dammerholt. Well, so we have here the acetylcholine, and we have the calcium pump. We need the calcium pump to operate in order to have an action potential. And when we have an action potential, there's ATP, and that's what makes the calcium pump operate. Well, when we don't actually have a volitional contraction, the calcium pump can run out of ATP. And even when we do have an action potential, the calcium pump can run out of energy, run out of gas. And when it runs out of ATP, it can get stuck. So it needs ATP to fire, for the muscle to fire, and it needs ATP for the calcium pump to get the muscle to engage. And when the muscle doesn't disengage, or the actin and the myosin don't disengage, they're stuck. And that's where we get the trigger point. Well, with the trigger point, what happens is you have all these little bits of actin and myosin. So, and what we actually palpate is this little nodule in the muscle, but that little nodule is made up of several little actin and myosin contractures. They're microscopic. And when we have these microscopic actin and myosin contractures, unfortunately, it sets off a chain of events. Now, this is, I'm just going to show this to you later, but this is actually out of this David Simon's article. And what he shows is a knot, just like we saw in Janet Travell's picture. We see a knot right here. It's a contracture. It's not under volitional control. And then we have all these sarcomeres here that are being pulled. While these are engaged, these are being pulled and stretched. Now, what you see here, this would actually represent the taut band that we feel in the muscle. So Janet Travell defines a trigger point as a hyperirritable spot within a muscle and within a taut band. So this is actually one sarcomere contracture, and if you had several of these, that would be the palpable nodule, and that's what we're after. But I want you to draw your attention to the fact that David Simons showed that these sarcomeres were in a stretched position, and these were in an engaged position. And when you have these actin and myosin engaged, they can't generate any more force than what they already have. So when you go to use the muscle, these actin and myosin are engaged, and so you have a strength deficit. It's not a purposeful use of energy here or use of force. And so that leads to a set of other problems. So when we have a trigger point, and there's all kinds of studies. If you've taken the MyoPain Seminar series, you've heard this. If you haven't, you can listen to some of the other webinars as well. But we have decreased strength because the trigger points are preventing the muscle from producing optimal strength because they're already engaged, and they're preventing full length. You can't take the muscle through the full length of its excursion because the actin and the myosin are engaged. So now we have dysfunction. And that's really what we're treating, is we're treating a dysfunctional muscle, can't generate full length or full strength. We're also treating a dysfunctional nervous system because the nervous system becomes hypersensitized, just like you would if you have RSD or fibromyalgia or some other sensory problem. We are treating a dysfunctional nervous system that's become hypersensitized. Oh, okay, well, I didn't realize Jan was going to be on this, but I'll talk over him for just a minute. We have a blood flow problem. Okay, so if we have a blood flow problem, then we have an oxygen problem. And what happens is, as the actin and the myosin become engaged and the muscle becomes tight around the capillaries, it affects the capillary return, and we get a retrograde blood flow. And with this, we have lack of blood, we have lack of oxygen. And so you can live, I tell my patients, you can live days without food. You can live, days without food. You can live a long time without water, but you cannot live but minutes without oxygen. And so when you don't have oxygen to the tissue is going to be damaged, then cells are going to die. Well, when the cells and the tissue start to become damaged and die, they put off an acidic response. And so our pH starts to drop. And when we have the pH dropping, that gives us, you can see here the pH that Jay Shaw saw in his research was about 4.1 in an active trigger point. And when we see the acid or the milieu of the trigger point become acidic, it's almost like citric acid. So I tell my patients, it's like if you had a cut on your hand, you wouldn't want to work with lemons or lemon juice because it would sting. So we're dealing with the milieu of the trigger point. Is not a nice environment. It's very, very painful. Well, that sends a stimulus from the tissues to our spinal cord. And when we have the signal going to the spinal cord, the low pH, the low pH will set off a response from ASIC 1 and ASIC 3. Well, ASIC1 and ASIC3 is very important because when you have the acidic milieu and an increase in ASIC1 or ASIC3, then you have an increase in calcitonin gene-related peptide. So there's all these chains of events that go on. And the simplest thing in the world is just to treat the trigger point. Get rid of the trigger point, you can get strength back, you can get length back, and it will help with the sensitivity of the muscle and even the nervous system. So all these chains of events are going on. We have a lack of oxygen, we have a decrease in the pH balance. That causes an acidic milieu. The acidic milieu starts to facilitate ASIC1 and ASIC3. The ASIC1 and ASIC3 increases the calcitonin gene-related peptide. And when we have an increase in the calcitonin gene-related peptide, then that causes a chain reaction which decreases the acetylcholine esterase. Now, I know I'm throwing a lot of stuff at you, but again, you can go back and watch this if you want to again, but these chains of events are pretty important. If I take you back to the action potential, we need acetylcholine, which you see here, right here in the middle of the synaptic, or the end of the nerve. That acetylcholine will accumulate here on the bottom of the nerve and then be dumped into the muscle to create an action potential. And if you look over here onto the left-hand side of this illustration, you can see that the acetate and the choline are separated and recycled for another contraction, another action potential. So it's a very efficient system. Well, what recycles these acetate and the choline is the acetylcholine esterase. And so if you have an increase in calcitonin gene-related peptide, and then you have a downregulation or decrease in acetylcholine esterase, you can't recycle the acetylcholine. And therefore, it just stays there, keeping those actin and the myosin engaged. And again, the simplest thing in the world to do is to treat the trigger point and just get rid of it. So hopefully that makes a little bit of sense as far as the chain reaction that goes on. The other thing that happens when it's related to the pain is that when you have decreased oxygen and you have cellular death, the cells start to release a neuropeptide called substance P. That causes pain, and it exacerbates the pain signal. It doesn't matter what kind of injury you have. It doesn't matter whether you have a trigger point injury or a cut to your hand. It doesn't matter what happens. These responses are the same. And when you have a cut to your hand, or if you have a trigger point within the muscle and you have substance P being released, free nerve endings are picking up this stimuli, and it causes peripheral sensitization. The muscle becomes tender. So I can sit here and palpate my upper traps and go, okay, that feels, actually the one I have is over here. I can palpate through and it's no problem. And then I go right here and I go, wow, that's tender. Well, why would that be tender when the whole muscle is one unit, all innervated by the same nerve? Why would that section be tender? And it's because it's peripherally sensitized. I have a trigger point back there. Because all those things that I just described to you are actually going on, and I have peripheral sensitization. It's localized. So when you have, this is a C fiber here, and when you have signals coming to the C fiber from my shoulder, it sends chemicals in both directions, back down to my shoulder, but it also sends chemicals back up to my central nervous system. So these chemicals going back to my shoulder, substance P and all these other things that go back to my shoulder, help facilitate or maintain that peripheral sensitization. These that go up to my dorsal horn start to cause some other problems. So as I said, if I just have chemicals going back to my finger or to the muscle locally, I have peripheral sensitization. The finger shows pain. Pain is functional. It tells you that you have acute pain, I should say, is functional. It tells you that you have tissue damage. Protect the tissue, let it heal, and once it's healed, the pain should go away. But in the presence of chronic pain, when the trigger point doesn't go away, that becomes problematic. That's no longer a functional system of pain. That is a dysfunctional pain. And as I said, just like fibromyalgia, just like RSD, or just like phantom pain, it serves no purpose because the tissue is not needing to be protected because it's no longer under threat. Well, we know that within the trigger point, we have spontaneous electrical activity. And here, this is Dr. Hubbard's work. You have a muscle here with an EMG needle in the trigger point, an EMG needle in the muscle itself. You can see a low resting tone of the muscle here. And then you see all this electrical activity in the trigger point itself. And that's because it can't let go. It's just engaged all the time. Again, this is not the way our muscles are supposed to work. We should have a low resting tone and then a firing electrical activity and then resting again. But with the trigger point, that's not what's happening. We've got a dysfunctional muscle. It can't produce full length. It can't produce full strength. So this is not as fancy as some of the other illustrations. This is something that I put together. Hopefully it'll work. We have a trigger point here in the infraspinatus, and then the pain is sent through a primary nociceptor, and the dorsal root ganglion is here, remember, sending chemicals back to the muscle and to the dorsal horn. This nociceptive signal goes to the dorsal horn, synapses with a secondary nociceptor, and goes up to the brain. And in the instance of the cutting of the finger, the brain says, yeah, that hurts, okay. Or if you have your hand on the stove, it may say it hurts. It causes a protective response. So a motoric response will go down and will help you pull your hand up off the stove. Before you even know it, your hand is off the stove to stop the damage to the tissue. It's a protective response, or a spinal reflex loop. Well, that's very, very important. But if this signal that goes through the primary nociceptor is sustained, it's intense, or it is repeated, then this constant bombardment of nociceptive information into the dorsal horn causes an accumulation of chemicals, much like that accumulated within the trigger point. And that lowers your threshold. No longer do you need the same stimulus that you needed before. Perhaps you just touch it with your finger. I've had patients come in and say, my shirt feels like it's making my shoulder burn. Well, that's crazy. That's allodynia. That's not functional pain. That's dysfunctional pain. Or I've had patients tell me I can't sleep with the sheets on my feet because it causes too much pain. So in those instances, we have central sensitization. It's no longer peripheralized. It now has caused the central nervous system in the dorsal horn, and actually even in the brain, has caused them to lower their threshold and pick up on signals that it normally might ignore or not pay as much attention to. The nervous system has become hyper efficient. And that's where we come in most handy, is when patients have these types of things, when they have the allodynia, or they have a trigger point pain that won't go away, or they have pain that nobody else can explain. And I can tell you, and I'm sure you guys could tell me, a number of patients that have come your way that have been to this therapist and this therapist and this therapist and had this image and injections and medications and not gotten any better. And so since all that stuff has been ruled out, we start looking for the trigger points, and we're able to find the pain. And so in the instance of, or we have the instance of people coming in with things in the hand and nobody's looking at the infraspinatus, so they're coming in and we're looking at the forearm and saying it's got to be a lateral epicondylitis because that's where the pain is. And I go, no, it could be the infraspinatus. It could be any number of muscles that refer pain to the forearm or the elbow. And so that's why I think it's so important to understand what's happening with the trigger point, because when you get to this point of hypersensitivity, if you get referred pain that is not actually where tissue damage is, but in another location, that referred pain, that's where we as therapists or healthcare workers can help our patients and look for those trigger points that can refer to that area. Now, many of you have done the dry needling courses, I think, and you at this point you might go ahead and do dry needling and eliminate the trigger point and get your twitch response and all is well, and that's great. But what happens when you can't needle? Now, I've been able to needle now in Florida for 3 years. I've needled a fair number of my patients, but there's some patients that I have that don't want to be needled. You know that there are some contraindications and there are some precautions that we don't use needles. So what do you do? So this is where the manual therapy comes in handy in treating the trigger point from a manual perspective. So this is connective tissue. So now I'm going to shift gears and look at the connective tissue briefly, because I think this is important too. We'll go back to the trigger point. But this is connective tissue, and what you're looking at here in the middle is that's scar tissue. Over here on your left, that's nice, healthy collagen fibers all lined up in the same direction. But this is actually scar tissue. And scar tissue itself can limit range of motion. Adhesions can limit range of motion. And that can come when you have tissue that is immobilized. There are 3 different types, depending on what you read. And this is what is most subscribed to, is that there are 3 different types of connective tissue. One of them is dense, regular connective tissue, like ligaments or tendons. And dense, regular connective tissue is made up primarily of collagen. And you can see the collagen here, this pink tissue is collagen fibers. You can see the black lines, those are actually the nuclei of the fibroblasts. And we got a little bit of lighter pink in here, and that's ground substance. And ground substance is responsible for lubricating the tissues, whether it be muscle, connective tissue, joint. Ground substance is vital to proper movement. Then we have dense, irregular connective tissue, and this could be your capsules or your aponeuroses. The thoracolumbar fascia is dense, irregular connective tissue. Again, it has lots of collagen, has fibroblasts, has ground substance. It's a little bit better vascularized than the tendon or the ligament, and it has a little bit more innervation. So it provides a little bit better proprioceptive information. So we need the dense, irregular connective tissue to move probably more than we do the dense regular. So we need the capsules to be fairly mobile. Tendons and ligaments, we don't want them to deform a whole lot. They can deform some, about 4 to 6%. But the capsules and some of the other tissues, we want the thoracolumbar fascia, certainly. You'll see why in a little bit, why we want mobility within that tissue. And then lastly, we have loose, irregular connective tissue. It too has collagen. It has fibroblasts. It's very well vascularized. The superficial fascia would be an example of loose, irregular connective tissue because it has a great blood supply. It heals very, very quickly. So I explained to my patients, look, when you have a total knee replacement, they cut through the skin. And even though the skin is healing up very quickly, it takes a little bit longer for the capsule to heal because the blood supply is not as good in the capsule as it is in the superficial fascia in the skin. And you over there, if you've got a rotator cuff repair, yeah, you've got to wait a long time because, yeah, I know this person with the total knee is up and walking, and we're trying to increase the range of motion of the knee, but the tendon takes a little bit longer to heal. And so that's where we get our protocols, is primarily based on the types of tissues that we're dealing with. But nonetheless, we have the fascia and the connective tissue has specific functions. And for years, we would read through material and say the fascia and the connective tissue holds us together. And that's true, it does. It holds us together. But it also does some other things. And I like Peter Howing's work. Again, these are older studies that came out in the first or the second Fascia Congress. And what he looked at, what he saw is that fascia transmits forces, and this is where we get our anatomy trains and some of the other courses, some of the other material that's out there, is that the fascia, if you go into a dissection, which MyoPain Seminars offers a dissection course, and other places offer dissection courses. So if you get a chance to do that, go ahead and do it. People always say, I wish I could get back in the cadaver lab. But if you can get into a cadaver lab where they're looking at fascia instead of just muscles and tendons, you'll see the fascia from the posterior shoulder comes down into the triceps. So the fascia from the infraspinatus comes down into the posterior triceps continuously, and then the fascia from the triceps actually comes down into the dorsum of the forearm. And you see these fascial planes all over the place that interconnect with the muscle. And what Peter Howing says is that when the triceps contract, that fascia pulls on the forearm and actually helps with wrist stabilization. So if you've got your arm outstretched, I don't know if you can see, an arm outstretched like this, and I'm holding up my shoulder because of my rotator cuff and my scapular muscles and my deltoids, all of that, all the contractions are pulling on this fascia all the way down to my wrist to help me with stabilization. So it does more than just hold us together. It actually transmits forces from one muscle to another. And these are just a few of his studies. It's not just from muscles that have similar function, but it's also between agonist and antagonist. So I would encourage you to find some of these pieces of research and read through them. They're very, very interesting. So this is from Strolling Under the Skin, and I'll show you some pictures here. You can see the collagen attached to the tendon and how it's also attached to the adipose tissue and the underlying of the skin. And so when the tendon moves back and forth, it actually transmits forces into the skin. And what you wouldn't see was that this tendon is actually connected to tissue underneath. And that'll be very important when I come to another slide here. You can see here on the left, this is out of Dr. Gambaranderto's Strolling Under the Skin. You can see here the muscle here with the fascial connections. And imagine, if you will, the fascial connections, not just from this muscle, but also connecting to a neighboring muscle. Last year, the year before, I went to one of the dissection classes that we offer and started looking at the fascia in the forearm. And not only was each muscle encapsulated within a fascial sheath, those fascial sheaths were woven throughout the entire forearm. Excuse me. And here you'll see collagen fibers. So these are collagen fibers, these thread-looking things, and this glistening liquid is actually ground substance. And so the ground substance helps keep the tissue lubricated and allows the mobility of the collagen fibers without getting stuck on each other. So what happens with immobilization? So if we have a trigger point, the trigger point is limiting us from going through the full length of the muscle. It's also limiting us from generating full strength in the muscle. So we've got a dysfunctional muscle. Within the muscle, we have collagen fibers. Within the tendons, we have collagen fibers. And these little guys here that look like brushes, those are GAG. That's glycosaminoglycans. And the ground substance is made up of glycosaminoglycans and water. And because these GAG have like charges, they have negative charges, they repel each other. So they push each other away. And that creates that space for those collagen fibers to move and transmit the forces. When we have immobilization, one of the things that happens is we lose GAG. We lose the lubricating quality of the connective tissue. And so when we have immobilization, we lose the ability for the tissues, not just the muscles, but the tissues to go through the full length and also generate full strength. So some of you guys will get these illustrations. Some of you guys are probably too young. But anyway, nonetheless, we're not able to take the fascia through the full length and the full strength. So hopefully you can see that I'm building what happens to the connective tissue when we eliminate the trigger point. And I don't think anybody really knows. So when we look at the way that we move as human beings, there is an architectural principle that was started with Buckminster Fuller called tensegrity. And what he said is that the tensegrity principle is built on the fact that you have compression resistant structures and you have tensile resistant structures. And when you have compression resistant structures, they resist compression and provide stability. And that's important. Brick and mortar buildings are very, very stable. They can withstand, if you're in Ohio, you see brick and mortar buildings because you have tornadoes. If you're in Kansas, you see brick and mortar buildings because you have tornadoes. Here in Florida, you'll see brick and mortar because we have hurricanes. But then the other is the tensile resistant structures. And I hope Jan would like this. Is actually the Rotterdam Bridge. We'll see if he recognizes it. But you have cables. You have a compression resistant structure, one compression resistant structure here, and then you have multiple tensile resistant structures. And the benefit of having the tensile resistant structures is that it allows for mobility. Now, you'll see these in California, you'll see these structures in Japan, because these structures have to resist movement of the tectonic plates when they have earthquakes. And so it is stable because it has the compression resistant structure, but it also allows for mobility. So this is the architectural principle of tensegrity. And we see this principle being used in all kinds of structures. Man-made principles here, like in, not man-made, sorry, natural structures like the honeycomb or the spider web. And we see it in man-made structures like a styrofoam cup. This is a styrofoam cup blown up, and we see in the cardboard. It provides strength, but it does allow for lightweight mobility. So some therapists or healthcare workers have said, well, what about the body? So we've got this principle of tensegrity. What about the body? So they coined the term biotensegrity. And this is a great web page if you want to go there, biotensegrity.com. Lots of interesting articles to read and examples. But biotensegrity not only goes from the bones to the muscles to the tendons, but it also goes all the way down to the cellular level. And this article will be provided for you. And it's amazing that this compression resistant principle and the tensile resistant principle are all the way down into the cells. The microtubules resist compression. These little green things resist compression. And then you have the cytoplasm and the microfilaments that will resist the tension. And so that not only helps with the cell maintaining its own structure, but it helps with the mobility of the cell. So oftentimes people think that cells are just floating around. Well, they don't. They actually migrate mechanically, or some of them do. So I hope that you'll enjoy this article. It's a very interesting read. But the tensegrity principle, or biotensegrity principle rather, can be seen here as related to us as physical therapists. You have the compression resistant structures in the way of bone. You have the tensile resistant structures in the way of tendons, ligaments, fascia. And what's important about this is that if you think about little babies learn how to walk. And sure, they're not fully developed, but they've got probably more tensile resistant structures within their body than they do developed tensile resistant structures than they do compression resistant structures, because they're falling all the time. And when they hit the ground, that force, that ground reaction force, just kind of reverberates up through the fat and the tissue and the muscle and everything else. And they rarely break their bones as many times as they fall. But as we get older, I think, this is just my opinion, I think we lose the mobility more and more within the tensile resistant structures. And that's why I'm fascinated by anything that's related to the myofascial manipulation. I think that we are losing the mobility within the connective tissue, within the muscles via trigger points, within the muscle maybe via scar tissue or adhesions or from previous injuries. And that when we do have some kind of force entering into our body, if that force can't dissipate and be absorbed somehow, then it follows the path of least resistance and either it tears or we have some kind of bone break. So we're doing our part when we're getting rid of the trigger point to help restore the tensile resistant principle within the connective tissue. And I think that's very important. But what about the connective tissue? What happens to the connective tissue? Okay. We've seen this principle. This is from Andre Vleeming, and this is the force form principle that he has, the ring of the pelvis. And you have some very congruent joints in the SI joint and in the pubic ramus. You have very, very congruent joints. And that ring is a great way to distribute forces. In fact, the ring is a very, very strong structure. We see it in archways within ancient Roman ruins or ancient Roman structures. But what also helps with the pelvis, because it's not a perfectly brick, it's not a solid brick and mortar, it has to provide some mobility with gait. And it has to transmit the forces of the ground reaction forces coming from the legs up into the spine. There are ligaments that hold these structures together, and there are muscles that will help distribute the forces. And so the force-form combination provides for mobility and stability. We see this not only in the pelvis, but we see this within the thoracolumbar fascia. Again, it is dense, irregular connective tissue. The collagen is oriented in an irregular fashion, and that's because it's got pull from several different directions. We've got the gluteus maximus pulling on the thoracolumbar fascia from below. We've got the transverse abdominis pulling, well, not only transverse abdominis, but the abdominals are attached to the thoracolumbar fascia and will pull from the side. We've got the lats pulling from above. And mobility within the thoracolumbar fascia is very, very important for the purpose of locomotion. So when you think, oh, I've got somebody with a shoulder problem, then I'm treating the trigger points within the lats and I'm needling away, or I'm treating it manually. That's great. You're getting rid of their pain. Perhaps you help with the shoulder flexion, being an internal rotator, extender, and adductor. Hopefully you're helping with the shoulder flexion. But what you're also doing is helping the tissue absorb forces of locomotion. And here in this deeper portion, you can see the thoracolumbar fascia goes all the way down into the sacrotuberous ligament. So we need, here's the sacrotuberous ligament right here, we need the mobility of the thoracolumbar fascia because the forces are being transmitted from the muscles into the bony structures, but also into neighboring connective tissue and neighboring muscles. So it's very important for locomotion. And you can see here is a representation of the thoracolumbar fascia, the dense, irregular connective tissue that's like in a cross fashion. And the purpose of this is for disassociation with walking. And this is done by Zorn. It's a poster that he presented at one of the conferences. And he showed that it's very important that you get this alternating pattern between the arm and the leg. The arm goes into flexion, the leg goes into extension. The arm goes into flexion, the leg goes into extension. And the benefit of this is that as the arm goes into flexion and the leg, the arm goes into flexion on one side and the hip on the other side goes into flexion, so scrap that first part. The arm on the right, we'll say, goes into flexion, and the left leg goes into flexion. It creates potential energy here in the thoracolumbar fascia that snaps back almost like a spring. And that aids in the locomotion. The disassociation of the upper extremity and the lower extremity loads the spring of the thoracolumbar fascia, only if you have the mobility there, and only if you have the mobility in the lats, only if you have the mobility in the glutes. So you get my point. We need the mobility within the muscle, so we need to get rid of the trigger points. We need the mobility in the fascia, not only in the thoracolumbar fascia, but the fascia in the lats, the fascia in the glutes, the fascia in the hamstrings, and that will help us make the locomotion more efficient. Again, I will submit to you, I think as we get older, we lose this pattern, and people tend to have more lateral motion instead of rotational motion because of either strength or immobility. They've lost the mobility. And when we have a malalignment of the joint, that puts unnecessary stress on the connective tissue, and it makes it inefficient. So not only do we need to get rid of the trigger points and provide an environment for adequate contraction and length, or strength and length of the muscle, we need appropriate positioning of the muscle of the joints, and we need adequate mobility within the fascia. So there's lots of things. I told you I was a clinician. There's lots of things that we need to think about. And you can see here some illustrations from the anatomy trains where it creates that stirrup almost, if you will, allow me to use that term, that cross across the back, the lats pulling on the thoracolumbar fascia, translating down into the glutes and down into the hamstrings. And there's these certain lines of pull. And as I said before, the purpose of that is to help us with our locomotion. But it not only occurs here in the posterior aspect of the back, it happens in the chest, the fascia across around the pectoralis major and into the arms and the posterior shoulders, into the neck. It's just amazing. And Ida Rolfe even mentioned this years and years ago before we had any of this. And she would say that if you have some kind of restriction down here in the lower quadrant of the fascia, it could limit shoulder mobility up in the upper quadrant. So this goes quite a ways. If you look at the muscle here, we have the muscle, which is this red. That's actually the muscle fibers. When we talk about muscle, we forget that there's fascia there. And so 50–60% of your muscle is made up of fascia. And when you take the muscle out, this is an electron microscope image. When you take the fascia out, you can see this is where the muscle fibers would go. And if you look here at pulling out a little bit, you have here the endomysium. So what's surrounding each and every muscle fiber is the endomysium. And then all these muscle fibers encapsulated in endomysium. If you go up into the top right, you can see the epimysium. And by the way, the only thing that goes from origin to insertion in a connective tissue way is the epimysium. The endomysium and the perimysium do not. But you can see that with the endomysium, all these muscle fibers create a fascicle. And then if you have fascicle and fascicle and fascicle and fascicle, what divides the fascicle is the perimysium. And I'll go back to my previous picture, it shows a little bit better. You have muscle fibers, and surrounding the muscle fibers are the endomysium, and then you have a fascicle, and each one of these fascicles is separated by a perimysium, and then the muscle fiber, or sorry, the muscle itself is surrounded by the epimysium. Okay, so that connective tissue is very, very important, and we know that the trigger point is within the sarcomeres, which is part of the muscle, but what happens to the connective tissue? Again, an older study done by Smulder, and what he did in this study, he was a plastic surgeon who would correct a contracture of the flexor carpi ulnaris, and he would dissect the flexor carpi ulnaris and put it on the back part of the forearm and turn it into an extensor with training. And he himself said, I've been throwing this connective tissue away thinking that all it did was hold the body together, but now I'm learning that it helps transmit forces. And with the help of a physical therapist, he started looking and saying, how critical is this force transmission? So he did a couple of different things. One, he looked at the length of the flexor carpi ulnaris, and what he did was he cut it here. Oh, hopefully it'll show it. Okay, he cut it here at the pisiform. So he left everything encapsulated, all the fascia, all the connective tissue intact, and he looked to see what was the length of the flexor carpi ulnaris when he cut it, and he stimulated it with electronic pads. So he stimulated the muscle, caused a contraction to see how much of the muscle would pull back when the muscle was stimulated. And when he cut it from the pisiform, it barely moved. Even though the muscle itself was contracting, the tendon, the severed tendon, moved very little. What was restricting it is all these fascial connections. Then he did a little bit further dissection, and he released the rest of the tendon, this little bit of tendon here. He stimulated it with electrical current, and it pulled back a little bit more because it had lost the integrity or the attachment of the surrounding connective tissue. And when he did a full dissection of the full muscle and stimulated with electrical current, the tendon pulled back almost all the way. So the whole muscle was able to engage, and because there was nothing restricting it, no fascial attachments within the forearm, it could actually pull back. And so what he thought was the fascial attachments that are here with the flexor carpi ulnaris attached to the surrounding muscles, when the flexor carpi ulnaris contracts, it pulls on the neighboring muscles, and that helps generate force within the forearm. So maybe I shouldn't just dissect the whole thing. I need to be careful and not just throw this fascial away, or maybe spare some of the fascial attachments, because if I don't, I probably have to make my patient train harder because I'm losing the advantage of those fascial or connective tissue connections. The second part of his research was to take the wrist and put it in full flexion and then take it back into full extension. And he wanted to see how much of the muscle would pull, how much of the muscle would lengthen. And you already probably can figure out the answer. When he severed the tendon from the pisiform and he took the wrist from full flexion into full extension, it didn't move the muscle moved, the whole length of the muscle maintained. It stayed quite a bit. And then when he severed the tendon, it moved even more. And when he severed the whole muscle belly, then he discovered the same thing that he discovered with the contraction, is that those fascial connections were limiting the range of, or limiting the mobility of the muscle because of its neighboring connections. And so why does this make any difference? Well, he said, the fascia provides force transmission because of all of its interconnections. And if we just throw this stuff away as a surgeon, it can limit the mobility, it can limit the strength. And so I submit to you that if the fascial remains intact, but yet loses its ability to move, I think that it could further limit the range of motion and perhaps cause some general weakness. I use function tests for my patients a lot. We need adequate mobility of the muscle. We need adequate mobility of the strength of the joints. We also need adequate mobility of the fascia in order to make these motions. And I look at child development a lot, and you can see here we have adequate dorsiflexion for them to go into this position. We have adequate length of the soleus. We have adequate knee flexion. We have the center of, well, not quite, if you consider the center of mass with this huge noggin here, it's going to be over the base of support, but for you and I, it won't be quite the same. But we have to have adequate flexion in the spine in order to make these, make this position. And when we get older, I think what we do is we start to accumulate immobility or accumulate dysfunction. And so what we start to do is start to compensate. So we can't get our weight over our feet so much anymore without doing some compensations. Either we lose the mobility in our back or our hips or our ankles. And so we start to compensate going up on our toes, or maybe alternating. Instead of a bilateral squat, we go into a unilateral squat with some additional support. And I think a lot of this is caused by fascial restrictions, and it could be caused by trigger points. So let's go to treating the trigger point manually. So we've established the fact that, or looked at some things that says we've got a trigger point. The trigger point, we have an oxygen problem, we have a blood flow problem, we have a pain problem because we're releasing substance P, and all these different things that are going on. The actin and the myosin are engaged, they can't let go, it's not under volitional control, it needs our help. And with the trigger point, it limits the length and the strength of the muscle, but it also, I think, affects the fascia. So could we needle it? Yes. Could we use spray and stretch? Sure. We could do a lot of different things. But so I started looking up articles about manual treatment of the trigger point, and it's mixed. And instead of going through study after study after study after study and saying this one was pretty good, this one was okay, this one was not good, I found a systematic review done by our beloved Cesar Fernandez das Peñas. And what he did was he looked at a systematic review, and he looked at 3 different physical therapy techniques, manual therapy, needling, and then some other techniques that you can see there on the screen. And the ones that I'm mostly interested in were the manual techniques. So when he looked at the manual techniques, he looked at research studies that used ischemic compression. Now, some of them used just that intervention, and then some of them used a combination of interventions. But he looked at ischemic compression, spray and stretch, strain, counter strain, muscle energy techniques, trigger point pressure techniques, and transverse friction. And they graded each one of these on a scale of 1 to 10. And of course, if it was a randomized controlled trial, it got certain points. And if it had a certain N, it got certain points. Well, when he looked at those things, he found these at the manual therapy portion. He saw these 7 things. And when he looked at what was going on and how they worked, if I can get to my next slide, there were several that provided an immediate reduction in pain, and that's good. So the ischemic compression, spray and stretch, deep pressure, tissue massage, occipital release, and myofascial release gave immediate pain release. What they didn't look at in these studies is range of motion, strength, and length. They just wanted to see what happens with the pain. So this is good. We know that we can get some immediate pain release with using these techniques. The massage with exercise, the McKenzie technique, the strain counter strain wasn't really any better than a placebo effect. So, but some of the manual techniques worked pretty well, but there's something missing. Something with the ischemic compression and some with the deep massage techniques, in my mind, and again, I'm just sharing with you as a clinician, something in my mind is missing from those techniques, and it's the neurophysiological response. When we use dry needling, the way that we know that we have the trigger point is we get the twitch response. So we are palpating to identify the trigger point, stick the needle in, and we get the twitch response. Why? Because it creates that spinal reflex loop. It involves the nervous system. And when you have pain, your nervous system is involved. And so if you want to help facilitate the pain that's coming from the trigger point, you want that twitch response, you want that confirmation of the spinal reflex loop. And I think that's what was missing with the ischemic pressure and some of the deep tissue. And we'll see this in the study, so I'm pausing for just a second. With David Simon's study, we'll see this because David Simons and Janet Travell in their 2-volume book, Red Books, said that stop crushing it. It used to be years ago that people would just crush the trigger point and hold it, and the patient's wincing and your hands are getting tired. And back in 1999, when they wrote those books, they said, no, stop, don't crush it. They said, facilitate the nervous system. Get the nervous system, get that motoric response. Just as if you would put your hand on the stove and you have nociceptive information going to your central nervous system, which creates a motoric response to preserve the integrity of the tissue, do that when you're treating a trigger point. Get that spinal reflex loop. So I won't take you through this again, but from the diagram, we know the primary nociceptor goes to the secondary nociceptor, and then it goes to the brain. There's a recognition of the pain. That spinal reflex loop causes a motoric response. And I think what's important is that David Simons in this article said that when you get the contraction with a contract relax, these sarcomeres help pull out these contracted or contractured sarcomeres. Now, it was a hypothesis of his. He did not say that this was shown using diagnostic ultrasound or any of these other things. He said he thought by facilitating the nervous system, by activating the muscle, that these sarcomeres would pull out the knotted actin and the myosin. And I will agree to you that that we don't know whether this happens or not, okay? What we do know is that when these sarcomeres are in a contracted state, they're basically in a state of active insufficiency. They can't generate any more force. And I will submit to you that when we use that contract relax, that by putting pressure on the trigger point, either using a flat palpation or using a pincer palpation, we are facilitating a nociceptive response. But it is a recognized nociceptive response. The patient recognizes that I'm reproducing their symptoms. So one, that gives them confidence that I actually know what I'm doing. And two, it also lets them feel a recognizable pain. But I will also submit to you that whether David Simons was correct or not, by contracting the muscle with an active contraction and then a total relaxation, we are in essence producing that spinal reflex loop. And perhaps an inhibitory response is active and coming into play. Okay, so I think that's important, is that when we treat with that contract relax, not only are we perhaps pulling the sarcomeres that are in a contractured state out, but more importantly, we are relying on that same neurophysiological response, that same spinal reflex loop, causing the muscle to relax and be inhibited, just like it would, or in a similar way that it would if we were getting the twitch response. So I think we're not looking for that local twitch response like we do with the needling, but we are looking for that spinal reflex loop. And I think that's the missing component when we crush it or when we use an ischemic response. So if you're not using a contract relax, I have my patient, I'll grab the trigger point, I'll have them shrug the shoulder and relax, and shrug the shoulder and relax. And by doing that, I will feel the trigger point soften within my fingers. And usually what happens is my patient will tell me the jaw pain is gone, or the referred pain is gone, which tells me the central sensitization is now starting to calm down, because central sensitization is referred. And they'll end up having just localized or peripheral sensitization. And sometimes that too is completely being eliminated. And so I think it's because we're facilitating the nervous system, which is involved with the pain response, that's helping when we contract the muscle. So Hopefully that helps you in the clinic by treating a trigger point manually when you can't needle. And I don't know for sure, but I will submit to you that perhaps this is just part of that spinal reflex loop and a facilitation of a dysfunctional nervous system that was probably caused from a dysfunctional muscle. I think it's also, because I don't have the answer, sorry, but I don't have the answer of what happens to the connective tissue when we eliminate the trigger point manually, or when we eliminate the trigger point through spray and stretch, or we eliminate the trigger point through needling. I don't know what happens to the connective tissue, but it seems reasonable to me as a clinician that we probably need to do some kind of manual therapy, either locally, maybe some skin rolling, maybe some ironing or something like that to treat the tissue locally. Maybe we do a little bit of myofascial release. The choice is yours. It's a negotiation between you and your patient. But I think we need to do some kind of muscle play, something to the connective tissue, something to the fascicles, and something to the paramecium, the endomesium, and the epimesium. I think it's good to follow up with a stretch. And if you're like me, I take these things right into my home exercise program and give them a follow-up technique to take home. Okay, so I hope just for the last, I don't know, an hour, I've let you into my head as how I treat clinically. I do use the dry needling. I don't use it all the time because my patients don't always want it, and sometimes they have an aversion to needles. Sometimes they're pregnant and I can't treat the abdominals when they're pregnant, or maybe some other muscles. So, but I do treat it manually. I will palpate, much like I do with my needling, either using a pincer palpation or flat palpation, and then I just say whatever the primary function of the muscle is. If it's the upper traps, I'll have them shrug the shoulders. If it's sternocleidomastoid, you could choose side bending, but I choose rotation. If it's the infraspinatus, it's external rotation. And I find that it works very, very well. And when it doesn't work, I do resort to other techniques like needling or spray and stretch, but I do get pretty good results with the manual technique. So hopefully I've kept you 2 minutes over, so I won't keep you much longer. I have a couple of questions, so if you'll give me a chance to just answer those. For those of you that are looking for a copy of the webinar, it is being recorded, and a link to it will be sent to you in a couple of days. If you'll, as far as the compression technique, I don't call it ischemic compression because it's not really an ischemic compression. I just call it a hold relax or a manual technique. But how long does it take? It can take 15, 20 seconds. Sometimes it takes a minute or more. So I appreciate the question, and I'll go into it a little bit deeper. What I'll do is I'll palpate the trigger point, perhaps in the upper trapezius, and I'll get the trigger point within my fingers, and I'll say, is that your pain? And they'll say yes. And I'll do the same thing I do when I do my needling. I'll say, do you feel it local or is it traveling? I want open-ended questions. I don't want to suggest, do you feel that in your jaw? Do you feel that in the back of your head? I'll ask them, is it local or is it traveling? And if they have referred pain and I hold it, I maintain my pressure. I don't crush it, maintain my pressure. They recognize the pain. Is it staying where it is or is it traveling? Oh, I'm feeling that in my jaw now. I say, okay, now what I want you to do is I want you to shrug your shoulder, and then I want you to completely relax. And then I'll have them shrug their shoulder again and completely relax. The mistake that I see some therapists making is that as it starts to release, they add more pressure. Don't. Maintain that static pressure. And what happens is the patient will often say, are you easing up your pressure? And I'll say, nope, my pressure's staying the same. And they'll say, well, it's getting less. And I'll say, where do you feel it now? And they'll say, I no longer feel it in my jaw, or I only feel it underneath your fingers. And that is an indication that the central sensitization is being eliminated. And so that's kind of how it goes. And then what I'll do is I'll say, okay, because when I'm palpating it, remember we've got lots of little sarcomere contractures. I'll say, okay, are you still feeling it? No. And I'll say, okay, I'm going to move, and I'll move over here, and they'll go, oh, there it is. And it's like, nope, that's a different one. I want you to contract again. And oftentimes, whether it's manually or needling, remember if you have an active trigger point on one side and you have referred pain and it's too sensitive, what you can do is you can go to the opposite side and you can treat the opposite side because it's the same segmental innervation. And if they have an active trigger point on this shoulder, I promise you, they'll have a latent trigger point on this side. So if I have somebody who's so hypersensitized at the palpation, whether you're palpating and treating manually or palpating and treating needling, sometimes the palpation is worse than the intervention. So I'll go to the other side, and we can't get into it in this seminar because we've kept you far longer, but there is a segmental innervation, and sometimes I'll go, okay, I've got C4 here. Let me go see what's happening at C4 based on the segmental innervation, and I'll find that they have trigger points here up at C4 in the multifidi or the neighboring muscle, and I'll treat segmentally, eliminate that, and then I'll go back to the opposite side, and I'll treat the opposite side to eliminate, get that threshold to go back up, get that central sensitization to come down, and then they can tolerate more. So hopefully you can pick that up. Maybe I'll do another webinar on that if it's needed, or you can pick that up from another webinar that somebody else has done. But because we're dealing with central sensitization, we have a hypersensitivity, so you can treat the opposite side, you can treat another muscle with a similar function, or you can treat segmentally and get some pretty good results. Okay, if you'll give me just a moment, I'm gonna, do I have a video of the manual technique? I don't, I'm sorry. I'm sure there are some online. We may be able to make one. I'll talk to the folks at MyoPain seminars, and perhaps we can do a video and provide it for you. Can you use, I have a question, can you use devices? Absolutely. Can you use the Theracane? I have a patient of mine who plays tennis. Every month or so, she brings me some tennis balls, and we use them for the piriformis, we use them for the gluteus medius. I go out and buy foam golf balls because golf balls are too hard, tennis balls are too big. I'll use foam golf balls, and I'll have the patient lay down on, you can't see me, sorry, lay down on their shoulder, and I'll have them do external rotation and relax, external rotation and relax, external rotation and relax. So I will use devices, yes, as a home exercise program, okay? So in answer to your question, can you use other devices? Absolutely, okay? When does it always the acidic pH, is there a trigger point? Yes, absolutely. When you have tissue damage, and this is Jay Shaw's work, and I think we can provide that article for you as well. When you have tissue damage and lack of oxygen, the milieu of the trigger point does become acidic, and that's part of what causes the pain. So it does every single time produce pain from the acidic milieu. Okay. Let's see. Let me look real quick. Okay. Are the trigger points primarily formed in the muscle? And as far as we know, as far as I know, yes, it is a sarcomere contracture. Why do we use the term myofascial trigger point? Because Janet Travell said it's a myofascial trigger point. But I think it was wise of her to use that term myofascial because we don't know what happens to the connective tissue. And I suspect as our research continues that we will find out that in fact something does change within the connective tissue, and it may release when we release the trigger point. It certainly may contract when we use the trigger point. When we have a trigger point, we know from Robert Schleip's work, I haven't even gone into his work, but Robert Schleip, S-C-H-L-E-I-P, S-C-H-L-I-E-P. You can look up his work. He's presented at the Fascia Congress as well. His research is amazing. He shows that that the fascia actually has the ability to contract. And some of the circumstances by which they contract, we don't have time to go into right now, but if you look up Robert Schleip, or even if you just look up Fascia Congress, if you look up Fascia Congress, you'll be able to find several articles that you can read. Okay, a couple of other last minute questions. Let's see. How does these techniques work with Eros Danlos? If I can tell on Jan for a second, he doesn't know this story, but before I could needle here in Florida, I had a patient who lived in Daytona, Florida, about an hour south of me, that had Eros Danlos. Incredible pain, was having a really hard time, looked up Eros Danlos, saw Jan was treating patients with Eros Danlos, flew up to Bethesda, Maryland, and got treated by him. And then some of his patients will stay there, will get a hotel, will stay there for a number of days because they don't know where else to go. He treated her with needling. Now, here's the thing about Ehlers-Danlos. Ehlers-Danlos is a systemic condition of hypermobility. And so you have the fascia that just gives way. It does not provide the support to the joints, does not provide the support to the muscles that mine does and yours does. But yet, so they have constant contractions of the trigger points or constant contractions of the muscles trying to provide the stability, and that causes an enormous amount of pain from the trigger points. So what Jan did was eliminate the trigger points. Well, she went home, and what he didn't know was she felt great. I don't have a whole lot of pain. This is wonderful, but I can't lift my arm. I've lost the ability to produce force in my arm because those trigger points and the tightening of the fascia provided the stability. So in eliminating the trigger point, which causes tension in the muscle, he took away that ability. But she was thrilled because she was feeling less pain that she had felt in a long, long time. And so what I explained this process to her, I said, well, you went up and you wanted to get rid of the pain, and that's exactly what he did. You feel great. I feel great. Bring your husband up from Daytona. Let me show him how to do this contract, relax, trigger point release technique so that when you do start to have more pain, he can eliminate trigger points selectively. You can tell him when to stop. Okay, that's enough. I can still lift my arm, but the pain's no longer a 9. It's now a 3. You're going to have to live with some kind of pain probably, because it's the same thing. If you eliminate all the trigger points, you're going to lose out on the stability that the trigger point is providing because your tissue, your connective tissue is not. And so he did. He came up to St. Augustine. I showed him how to do the contract relax technique, and I never saw her again. And my understanding is that she was doing great. When the pain got so much that was a distraction to her, he treated the trigger point manually, and she was able to live her life maintaining that balance of stability from the muscle, not provided from the connective tissue, and eliminating the central sensitization and the pain. Okay, so it's a great technique using for Ehlers-Danlos. Okay. All right. How do you choose whether to use dry needling or manual therapy? It's a negotiation between me and my patient. The research suggests, the research that I've looked at, let me say that because I haven't looked at everything and read everything, but the research that I've looked at suggests that they are comparable. They work pretty well. And there are advantages, though, I think, to using the dry needling when you have somebody who is so hypersensitized, because the palpation can be worse than the intervention. And if I can palpate gently and I can use this very sharp needle to go in and eliminate that trigger point, I don't have to cause as much pain by holding the palpation and palpating the trigger point. So there are some advantages to using the dry needling. When my patient doesn't like dry needling, they've got an area of some kind of skin condition, other conditions where I can't use dry needling, the manual therapy does come into very effective play. Other interventions like somebody's asking me about the thermotherapy, the ultrasound, the laser. The research for the laser shows that it does work fairly well. Heat is like the others. It's no better than a placebo. The heat will cause vasodilation or capillary dilation, will bring in some blood, will create a neurophysiological response. Who doesn't like heat? I mean, give me a warm bath and I'm great. Let me go into a heated pool. That's great. I relax. That's a neurophysiological response that will help the patient relax. That will help the nervous system relax. A good night's sleep will help somebody relax. Decreased pain will help somebody relax. So we haven't even gotten into the aspects of central sensitization and other things that can heighten and cause more pain that have nothing to do with the muscles or the bones or the tissues or anything like that. So if you're stressed, your pain level is going to go up, your threshold is going to come down. So there's all kinds of other things that can contribute to your pain threshold. The laser, as I said, works pretty well. The thermo works as long as you have the heat. You take the heat off, and not very long after that, the pain starts to come back. Okay, and the ultrasound, again, is another form of heat, so that tends to work fairly well, but it only works temporarily. Okay, how to choose? Okay, we did that. Let's see. Forgive me for there any way, okay, and okay, we're closing down. Thank you for all the thank yous. How many sessions do you think are required to eliminate a trigger point? Great question, but kind of a loaded question. How many treatments, how many sessions are required to eliminate a trigger point? If we are palpating one trigger point in the upper trapezius, how many sessions does it take to eliminate that trigger point? 1. If I'm using manual therapy or I'm using dry needling, I can eliminate that trigger point in 1 session. But then I have to think about the dysfunction. I have a muscle that was being held, a portion of that muscle was being held in a shortened range. I say bones allow motion. You have 2 articular surfaces that allow for motion. I've never seen a hypermobile skeleton. If I've got a dead animal, I found a dead skeleton of a dead possum in my backyard, we picked it up bone by bone. It wasn't hypo, it wasn't stiff, it was hyper mobile. So the bones allow for articular surfaces that allow for mobility. The muscles are what make it move. The fascia translates or transmits the forces. The nervous system is what makes it controlled. So if I eliminate that trigger point, I have to then facilitate the nervous system to reinstate how to control that motion, because that's usually what happens is my patients are coming to me because they have aberrant motion. They have the trigger points because they've overloaded the muscle somehow through poor posture, some kind of activity that is overloaded. So how many sessions does it take to eliminate 1 trigger point? 1 session. I can eliminate several trigger points in 1 session, okay? How long does it take to help my patient overcome the dysfunction? That depends. And it depends on how many trigger points they have. It depends on how long the dysfunction has been going on. But I can eliminate that trigger point in 1 session, whether I do it manually or whether I do it with a needle, okay? Okay, I think we are wrapped up. We'll give a webinar on treating the opposite side due to the hypersensitivity. That could be a very real possibility if we do a webinar in central sensitization. Okay. All right. All right. I have no more questions. And oh wait, is it my opinion that eccentric stretching for the manual therapy of trigger points? Tricky question. Do I need to use eccentric stretching? I use passive stretching. And again, you're asking me for my opinion. I'm not quoting any research at the moment. I use passive stretching because it is easily reproduced with my patient population. Is eccentric stretching effective? The answer is yes. There are people that talk about you have to use eccentric loading when you're dealing with a tendon. And there is some research, although it's not a lot, there is some research that says it really doesn't matter. What the research says is that you have to load the fibroblasts. Well, how do you load the fibroblasts to produce collagen synthesis? Well, a simple contraction, concentric contraction, will provide stimulation for the fibroblasts to produce collagen or collagen synthesis. The eccentric contraction produces more force. So the thought is, if you use an eccentric contraction, you are going to get that stimulation to the fibroblast and collagen synthesis. But you can use eccentric, you can use passive, you can use devices, pulleys. We use pulleys a lot. So the answer to your question would be, I would use the type of stretch that your patient is going to be most compliant with. And that's why I use passive stretching the most, okay? And that's just my opinion. That's not a research thing. Okay, do I recommend exercises post-dry needling? Absolutely. And again, you're asking me my opinion because there's a lot of studies out there that combine dry needling with exercise. Where I start off with is isometric. And again, as a clinician, my thought is you don't know how to control that muscle. That's what got you into this mess to begin with. So I want to start with closed chain. Again, I use closed chain because I think of child development. How did we get the proximal stabilization in our shoulders so that we could then reach out and grab something while we stabilize ourselves in a tripod, 2 knees and a hand? It was through crawling. So I use closed chain activities with my patients. I use isometric activities with my patients, and I'll use some perturbations to help facilitate and retrain that nervous system. But again, the answer to that question is I use exercises that's going to help my patient be most compliant. Because if they're not compliant, it doesn't make any difference. Okay. But just again, to let you in my head, I use I use closed chain type of exercises. Okay, I'll take one more question. Have we experimented with E-stem with dry needling? Yes, I have. I've had somebody do it to me. I will back up. I have not done it myself because I've not been trained in it and I don't know how to use it. I have had it used on me. Again, because I'm going to use my stage here as a clinician and as an instructor, my opinion is that in the definition, the APTA's definition of dry needling, electrical stimulation is not included. So in my mind, if I'm using electrical stimulation in needles, I'm using intramuscular electrical stimulation. So I might get in trouble from this because my boss at MyoPain seminars may not like my answer. He can edit it out. But my answer is that I think electrical stimulation is a valid intervention for trigger points, whether you use it topical or use pads or whether you use intramuscular, but it's electrical stimulation, and I have a hard time calling it dry needling because it's not within the APTA's definition of dry needling. But have I had it done on me? Yes. And did it work? It did work. And I know people who use it, colleagues of mine that use it and are trained in it, as I am not, and get good results as well. It's just I have a hard time calling that dry needling because it actually is electrical stimulation. And I ethically would not feel right charging a dry needling charge or a manual therapy charge doing that. I would just go ahead and bill it as electrical stimulation. But I have seen it used and I have had it used and it was effective. So thank you for that question. Yeah. Okay, so before any other questions come in, I'm going to go ahead and close it. And thank you, everybody. I think everybody signed. I still have 83 people signed on. So thank you very much for attending. Yes.
Bob, can I make one comment?
Please.
I don't know if you can see me, but anyone else can. But the question about electrotherapy, I just want to comment on that.
Okay, I thought you might.
Well, I see it because you are a MyoPain guy, is how you were addressed, like as if MyoPain would be against electrotherapy and dry needling, which is really not the case.
No, I didn't. I hope I didn't project that.
The issue is, Roger, that Roger asked the question, that for a long time, there's very little literature that shows that adding E-stem dry needling has any major effect other than 10-15 minutes of anesthesia. So you can numb people a little bit with electricity, but whether it really makes a clinical relevant difference is rather questionable. So I know there are other dry needling programs that teach this, and we are actually looking into doing that as well in the future because the research is changing. There's much better research now. An article a few years ago that was published and really promoting or pushing for dry needling, over 70% of the references were acupuncture animal studies. That to me is not enough evidence to justify going into, okay, let's put a needle in bodies and put a current on it. If the clinical effect is only 10-15 minutes, that's a waste of my time, to be honest, and waste of the patient time. So yes, I've used electricity a lot with needles. In Maryland, we're very open to that, and I'm not totally sure I agree with Rob's point whether the APA includes that or not. It doesn't really matter. The APA does not set the rules in my mind. They're important, but the state boards set rules in the end. And some state boards, it's not legal. In Illinois, you cannot use electrotherapy with needles. It is against the rules about dry needling in that state. So there are states where you cannot do this. Because by law, you can't. It's not allowed. There are recently a few studies that are actually very promising, done on humans. They actually show a recent study, and I don't have the author in my top of my head, but they looked at low frequencies versus high frequency electrotherapy, and they really did not see much of a difference. But what they also said, you need to do it at least for 15 minutes, otherwise the results are negligible. So there is better research out. I keep fairly close track of all that. I write a literature review column every quarter, so we do look at that quite detailed. Once the literature is better and not just on animal acupuncture studies, I'd be the first to incorporate this into our course programs as well. But show me the literature and I'll show you that you're wrong, pretty much, because it does not really exist yet. And I know other people have different opinions of that, but that's kind of where I am as a myopain guy, as she said so nicely. But it's changing, but a lot of stuff we don't know yet. So that's really where I'm coming from. So I just wanted to grab the opportunity as I'm listening to this. I'm like, it's interesting. But 10 minutes of anesthesia to me is a waste of time. That's the same as using ultrasound on trigger points. It works fine. It's very effective. You can do that. You can eliminate trigger points with ultrasound, but the effects are very, very short-lived. So then why would you bother doing it? So just my 2 cents.
The only thing I'll say is I didn't feel like I was put on the spot either. I appreciate the question. I tend to be a little bit more conservative than Jan because I have had some very stringent battles here in Florida, and so I tended to walk the line, and the definition's very, very strict. But I'm an eclectic therapist. If you said spreading peanut butter all over your patient's shoulder would help them, I'd say give me the peanut butter. I don't care. I'll use whatever I can to help my patients. But we always have looked at a variety of techniques, and if you haven't taken our seminars, they are I would tell you they are updated. This man right here updates them regularly with research. And all kinds of stuff because we want to be able to give the best product that we can. So hopefully you have felt like this webinar was a part of that. And again, thank you everybody for coming.
Good. Thank you, Rob, for the presentation. It was very interesting.
All right,
we'll see you next week with Principles of Dance Medicine. Goodbye, everyone.
Take care.